always, the first Wednesday of the month from 11:30 to 1:30. A lunch, a top-notch presentation, an opportunity for networking. How many of you all are here for the first time? You've never been to a Dallas TAAP meeting before. Right. Thankful that you're here. Give me a hand if you would, please. So we always have someone to sponsor the lunch. If you're interested in doing that for future meetings, and folks, we are going to ask you to go ahead and we'll get this started. So if you would kind of halt some of the visiting over there and get to, and we'll dive into our program. We're going to have an opportunity here at the back end of our time here today to do that. But if you're interested in you or your organization in either speaking for one of our monthly meetings or sponsoring lunch, please see one of the board members. Board members, if you would stand up and wave and point out who they can contact. Amy Campy over here is our point person to gather that information. Amy, wave a hand, please. And so if you could do that, we would love to get you all on board. Today we have our lunch sponsored by UVA Behavioral Health. And Nate Reed is over here. If you would, first of all, give them a hand for providing our lunch. I'm going to ask Nate to come up here in a second and tell us briefly about UBH, but also right after that, then Steve Paul, one of our board members, will be introducing our speaker for the day. Our speaker will go noon to 1, and then after that, at 1 o'clock to 1:30, we'll have some networking opportunities. So I want you to make sure that you can take advantage of that. So Nate, if you would tell us a little bit about UVH.
All right, thank you. Hello, everybody.
Hi, Nate.
Hello. My name is Nate Reed. I'm new to UVH. I've been in the psych field quite a bit, and I landed a home at UVH, which I love dearly. And so we offer a lot of services there. First of all, UVH is located in the great city of Denton. Everybody knows that, right? If you're not familiar with UVH. And we have specialty programs starting out with Dr. Ross's program, and we specialize in trauma. And so we get patients that are coming throughout the United States, and we get them treated, doing good services for them. We also have a military program for active duty as well as veterans and family members of the military, and we offer programs for them as well. And we have adolescent program that from ages, we actually have a new program from age 8 to 12, and that's all outpatient services. And so at 13 to 17, we have programs for inpatient and outpatient for adolescents. We accept most major insurances, of course private pay. And yeah, I think that's about it. Does anyone have any questions about UVH? Thank you for allowing us to come here and sponsor this. We really appreciate it. And if you have any patients that are in need of behavioral health services as well as chemical dependency services, as you know, we do more short-term services, and some of the players here have long-term services. So we would be a great resource for you guys, as well as you'd be a good resource for us. All right? If there's no questions, thank you very much. Have Steve come.
I'll introduce Dr. Ross. Thank you. All right, I'm glad we got a big crowd today. You're in for a treat. I was going to introduce Dr. Ross just off the top of my head, but I wouldn't do him any justice. So I'm going to read a little bit from his bio here. This is really going to be a great afternoon. Dr. Colin Ross is an internationally renowned clinician, researcher, author, and lecturer in the field of dissociation and trauma-related disorders. He is the founder and president of the Colin A Ross Institute for Psychological Trauma. And I'm going to skip a little bit of this, otherwise I'd take up way too much of his time. But Dr. Ross has authored 29 books and over 200 professional papers, has reviewed for numerous professional journals and grant agencies, and is past president of the International Society for the Study of Trauma and Dissociation. He has appeared in a number of television documentaries and has published essays, aphorisms, poetry, short stories, and screenplays. Dr. Ross is adept at imparting complex information to diverse professional audiences on a variety of subjects. He has spoken widely,
that's true.
Wildly, Freudian slip. He's spoken widely and wildly throughout North America and Europe and China, Malaysia, Australia, and New Zealand. Everyone please welcome Dr. Ross.
Well, that was a very wild introduction. So I might stop at 12:45 because 1 a.m. is kind of late to stop. I get that right?
Yeah.
Time's right? 12 to 1?
Yep.
1 a.m.? Okay. So in an hour, I'm just going to be able to give you kind of a skim over of trauma model therapy. So I've been, since I left the great country of Canada in 1991, been here in the Metroplex, chartered Dallas, 91 to 97, moved over to Timberlawn, 97 to 2015, and then moved from there to UVH, which is owned by the same parent corporation, 3 years and a couple months ago. So I've been running a trauma program in the Metroplex for over a quarter of a century now, which is pretty good because I started when I was 12 years old. I think that's what I was. And also consult to programs owned by the same parent corporation at hospitals in Grand Rapids, Michigan, and the Los Angeles area. At UVH, I do groups myself in person, 3 a week, and I do video conference groups in the other 2 locations. So I'm actually actively involved. And we have a visiting professionals program, which you're very welcome to come to. Basically, you go, there's Nate now, wherever he is. You could go through him, you could contact UVH Hospital, you could contact me, and we could set up that you come and visit. Usually most people come for a day. You could come for 2 or 3 or 4 weeks. We've had people from Europe who come for a couple of weeks. Basically, you sit in on groups, see what's going on, sit in on team meetings, and see how it actually operates in reality. And one of the reasons I decided to set that up was when I was in medical school in Canada. In one day, I watched a surgeon work for 6.5 hours. It was an amazing procedure where the incision literally went from here to here. And so the person's completely opened up. He takes their esophagus out, tosses it out, takes a section of bowel out, moves it up, sews it in, sews the bowel back up, sews the lung back up. 6.5 hours. That's more than the total time I watched psychiatrists actually working in 4 years of residency. So like, how are we supposed to learn anything if we don't see what people actually do? So that's my main motivation. At that program, it's about 12 to 14 days average length of stay, quarter to third Medicare, mostly managed care. 95% of people have a dissociative disorder, 7% major depressive episode, 80% PTSD, 2/3 panic disorder, 60% borderline personality disorder, 60% substance abuse, 40% eating disorders. So, and this is just what people admit to. So, half, you may not be familiar with the concept of denial. You've heard of it? So, 50% of people admit to a drug and alcohol problem. Then so there's some who haven't admitted yet. Of the remainder, a lot of people are chronic self-mutilating cutting, lots of sex addiction, lots of eating disorder addiction, not so much gambling, but some gambling addictions, love addictions in general. So we're dealing with addictions all the time. And this trauma model therapy that I'm going to describe has quite a big addiction component to it. That actually works. So Traumatization Essentials is a webinar series I set up with my daughter. I have some cards in my pocket. She's a psychiatrist in Toronto. And it's a series of webinars monthly on trauma-related topics. And if you go to the website, there's a newsletter you can sign up for that has very practical tips on things, clinical suggestions, reviews of books and papers. It's very well written because my daughter reads it. And that's my general contact information should you want to email or have any questions of any kind. So trauma model therapy, which is the title of one of my books, is basically good for what ails you. So it's a very broad general model for mental health addictions all across the board. And so my home base is, since basically I was a resident, and since I finished my residency, my home base has been psychiatric inpatient. That's the world I operate in. I would say there's obviously psychiatric inpatients who are not doing any kind of psychotherapy, no time with nobody. Who are way too psychotic or disorganized or unmotivated. But I would say like 3/4 of people in psych hospitals, if we exclude like all the way out there psychotic people, 3/4 of people fit this kind of way of thinking and actually are interested in therapy and recovery. So I see it, trauma psychiatry, trauma model therapy, I see as general psychiatry. That really trauma is a huge driver of all kinds of things all across the mental health field, not a subspecialty. But it has the status of subspecialty right now. So the trauma model therapy is the how-to book, which these are available from Amazon or my website. It's very practical, case example strategies, therapist-client dialogues. So if you were interested in one of my books, I'd go for that one first. So trauma model therapy has these major components to it. The problem of attachment to the perpetrator, the locus of control shift, are like the two core elements. And then we have the problem is not the problem, just say no to drugs. Addiction is the opposite of desensitization, and the victim rescuer pentagon, is it? No, square? Triangle. So I'm going to go through this one by one and focus on the addictions aspect of this. So the problem attached to the perpetrator, ultra quickly, is illustrated in this picture. So this is a little hippo that was washed up in the tsunami and separated from its parents. And thank goodness there was this really cuddly, touchy-feely substitute mom available. So just the way that little hippo is leaning in is very touching, and it shows you the power of mammalian attachment. That you will, you must, you do bond, connect, attach, love, and need to be loved by an adult caretaker. So it's not about race, gender, culture, IQ. It's just being a mammal. You will, you must, bond, connect, attach. And in a halfway normal, reasonable family, it all works out okay. You end up with secure attachment, good self-esteem, trusting people in relationships, unless they're politicians. So then, that's the normal, regular, halfway okay, reasonable family, which we never get to see examples of, because everybody who comes to the trauma program came from some kind of big, chaotic trauma family. Physical abuse, sexual abuse, family violence, emotional neglect, physical neglect, loss of primary caretakers in all different combinations. And so they had the problem of attachment to the perpetrator. How to form an attachment to somebody who might literally kill you or abandon you, but certainly attacking you, scaring you, doing all kinds of crazy stuff. So you end up with approach, connect, bond, love, attach, and that's okay some of the times, because the parents are okay some of the time. But then a lot of other times, it's fear, flee, avoid, hate, I'm out of there, shut down. So I call that mode A, mode B. So you just get set up in this approach, avoid, love, hate. Oh, you're a little too far away, I'm feeling abandoned and lonely and small and scared, I'll just pull you back in. Oh, you're a little too close, you might be a perpetrator, now I'm getting scared, I'll push you away. Back and forth, back and forth. This I see as the inevitable outcome of the problem of attachment to the perpetrator. And when somebody comes into the inpatient unit, they can't act out all over the place. They're not too busy cooking and taking care of things. So they have to do crazy stuff like being mindful and introspecting and homework assignments. And it starts to sink in, the core realization. I loved the people who hurt me. I was hurt by the people that I loved. Both things were true. I had both sets of feelings, and I felt really small, scared, sad, lost, and lonely. So underneath all the addictions, all the diagnoses, all the behaviors, all the social roles, is a small, scared, sad, lost little kid. Whether that's just an inner child in the sense of unresolved feelings from childhood, it's just a metaphor, or somebody with dissociative identity disorder who the inner child comes out and talks to you, totally different tone of voice. Or it's sort of like an internal ego state, inner child who's somewhat separate. Maybe you do or don't visualize the child internally. So there's a inner child spectrum. In almost everybody, if we include, it's just a metaphor or figure of speech. Basically, everybody in the mental health field has some sort of unresolved feelings from childhood. So this inner child metaphor applies no matter how differentiated the inner child actually is. And therefore, we've got small, scared, sad, lost, lonely, grief, and a lot of the work of the treatment is mourning the loss of the childhood that you never actually had. The locus of control shift. It's the second main idea. So I'm going to go over those fast, and then I'll give some clinical examples. The locus of control shift is sort of like attachment to the perpetrator in that it's not about your race, gender, culture, IQ. It's just how kids think. So this is cognition, so it's not all mammals. And how all kids think, if they're down sensor motor, concrete operations, primary narcissism, they think that they're at the center of the world, the whole world revolves around them, and they have this magical power to make things happen. And there's a gigantic cognitive psychology literature about all of that, which you learn anyway by being a parent, even if you never took a psychology course. So in the normal course of events in the healthy normal family, I heard there's 3 of those in Texas. In the normal healthy family, you learn that you're lovable, people are trustworthy, you have good self-esteem, it all works out. In the big trauma family, you shift the locus of control, which is where the control point is, from inside the adults to inside yourself. Automatically, because that's how your brain processes the world. I'm at the center, I cause everything. So you end up with this ingrained belief that you're bad, you caused it, you deserved it, it's your fault. Which the perpetrators reinforce over and over and over by what they do, how they treat you, sometimes what they say out loud, and what they fail to do, which is just be halfway decent, consistent parents who are there and giving you unconditional love. So the messages get delivered numerous different ways, many different levels, relentlessly, and then you go to school and you get bullied, then you get molested by the high school coach, then you get assaulted at the frat house, then you have the first abusive husband, the second abusive husband. So it gets massively reinforced from the outside. I'm bad, I caused it, I deserved it, it's my fault. And then you get all this negative self-talk. I'm bad, I caused it, which reinforces it internally. So people come in, average age in the program is in the mid-30s. You can't be younger than 18 by definition. Most people are in their 20s, 30s, 40s. We have some though in 50s, 60s. Phew, that wasn't me. And they don't say, oh, Dr. Ross, I'm glad that you're running cognitive therapy group today because I have a cognitive error. They go, here's an absolute scientific fact that I'm going to state to you with total certainty. I'm bad, I caused it, I deserved it, it's my fault. So really holding on to it tight. So I was noticing this pattern, first couple hundred people, couple thousand people, and I said to myself, well, why does everybody hold on to this preposterous, ridiculous idea that children deserve to be abused? It's apparently not the case, so what's wrong with these people? So I could have gone, they're a bunch of borderlines or this or that. I could have explained it as they're basically broken, fundamentally wrong, bad, mentally ill, probably their genes are off. I rejected all that way of thinking and all those attitudes and said, there's got to be a reason for this, which is how I came up with this concept of this is totally normal childhood thinking. You automatically shift the locus of control. It's not an option. It's not you will or you won't. It just works that way. But then that doesn't answer the question of why do people hold on so tight? They're borderlines, they're this, they're that. And the way I figured that out is you shift the locus of control. Now you're not powerless, helpless, trapped, overwhelmed with no solution. You know what the problem is. You've got it contained inside you. All you have to do is decide to be a good little girl. Mom and daddy will see that you're trying better and they'll treat you okay. So blaming yourself happens automatically. It's not an optional defense. But once you blame yourself, then that sets up the illusion that you are in control, you've got the power, you're the mastery individual, and you can fix it. So we would not want to have the illusion of power, control, and mastery. So then that reinforces it over and over. And then we We do a little side detour. Instead of going to UBH, we go to the battered spouse shelter. We're looking at the intake. We're having a little case conference. Oh, well, this woman came in and she was, by her behavior, saying, I'm out of there, I'm not gonna take it, I don't deserve it, he's a perpetrator. That's what she's saying out loud with her voice. But look, this is the 8th time she's been here. What happened all the other previous times? When she was in that, I'm out of there, that mode B, you're no good, I'm not gonna take it, I don't deserve it. She got on a slippery slope and slid down to posture's not so good, energy's not so good, more hesitant. Well, he's been under a lot of stress. And what we start hearing is, really the problem is that I haven't been a good enough wife. I'm gonna go back and be a better wife, then he won't be so stressed out, and he won't have to hit me anymore. And she goes back, and he's very happy to agree that that's true. He loves her, he's not gonna hit her anymore, he's very glad she's trying harder, and everything's just great for a few weeks or a month or two, kapow, she's back at the shelter. So the problem of attachment of the perpetrator is not a theory about her childhood. It's dominating her life in the present. She's away from the perpetrator, she's in mode B, she's out of there, she's going back to him, she loves him, he's the greatest, back and forth, back and forth. And the locus of control shift is not a theory about her childhood. It's dominating her thinking, her decision-making, her perception in the present. I was a bad wife, I'm gonna improve my performance, then he won't have to hit me anymore. So we see the locus control shift operating all the time in numerous different ways. It's driving self-hatred, self-blame, self-punishment, consenting sort of consciously, maybe not exactly consciously, to unhealthy relationships, battering relationships, cutting on yourself. What we want to do, obviously, is reverse the locus control shift. We want to have it sink in that no child deserves to be abused. That includes you. It wasn't your fault. You didn't cause it. You deserve unconditional love, protection, safety, like every other kid on the planet. The reason you didn't get it was them, not you. And then the person goes, oh, thank you, Dr. Ross. Now I have good self-esteem and I don't have to cut anymore. It's not quite so easy for a very good reason. Because when you reverse the locus control shift, okay, you get rid of the bad, no good, self-hatred, self-punishment, but you also get rid of the illusion of control, power, and mastery. Now you're just small, scared, sad, lost, and lonely. So getting rid of the self-blame and self-hatred throws you into the scared, lost, abandoned little child feelings. And I always say nobody in their right mind would want to feel those feelings, so then people don't. They scramble in all kinds of ways to avoid their feelings in their situation. So that's a locus control shift. The problem is not the problem, illustrated by this humorous slide here. Not so humorous if you're the person hanging in space there. So this person's got a very ugly problem, which is if the person up top lets go, it's not going to be a good day. But actually this problem of hanging in space is the solution to another problem, which is how to get over the overhang. So this is basically family systems thinking. The identified patient, the presenting behavior is a solution to some problem in the background. And we apply that to all symptoms, all diagnoses, all everything. Sometimes we're going a little overboard, it's not true, but most of the time it is. We want to know the person's story. So our motto is not what's wrong with you, it's what happened to you. And then we normalize, normalize, normalize all the time. We're always talking about fight, flight, freeze, mammalian defense systems. How would any person feel, any kid, going through what you went through? And I commonly use the analogy of, which I like even more now because I have 2 sons who are orthopedic surgery residents. They send me these weird x-rays with incredible rods in people's bones. I get to hear about the amazing accidents that people have. So the analogy I use frequently is somebody's hit by a drunk driver, now their femur is sticking out through their skin. And they come into the ER, and the ER doctor or the orthopedic guy comes in and goes, well, that's a lot of attention-seeking behavior. No, it doesn't say that. He comes in and goes, I wonder what genetic abnormality this person is suffering from. Doesn't say that either. Oh, that's pathological. No, it doesn't say that. But the doctor does notice this is a pathological disordered condition. This is not normal. But it's normal if you've been hit by a drunk driver. So I use that analogy all the time. All these symptoms, all these behaviors, they're not healthy, quotes, normal, but they're very understandable normal if you've been through that kind of trauma, such as a giant train wreck of a childhood. So normalize, normalize, normalize all the time. So when we fit all the symptoms into the story, they make sense. They're not just coming from your brain on the fritz. And they have some sort of survival strategy behind them, defense mechanism, coping strategy. It's not healthy, but it's understandable. And then what we really want to treat is not your unhealthy coping strategy. We want to know what's the problem behind the problem, which is always a bunch of lousy feelings, lousy situation. And then we want to help the person develop affect management skills, self-regulation skills. So we're actually helping treat the problem in the background. We're not actually treating the drugs, the alcohol, the eating disorder, the PTSD, any of these diagnoses. We notice that people have them. We don't ignore them. We certainly refer people to AA programs. But really our treatment focus is not on the diagnostic category or the specific behavior. It's on how to cope with, solve the problem in the background. And then when you figure out a healthy way to do that, it's a lot easier to let go of your addiction. That's the idea. Simple, just takes one session. So just say no to drugs is the addiction part of the model, which is, we all know about 12 steps. So not every session, but once in a while, if somebody has an addiction or we're on the topic of addictions, I'll go, well, have you ever been in a 12-step group? Yeah. 12 steps are good, but there's a step that often gets missed out, which is step 0.5. Step 0.5 is, which actually in reality is all rolled into step 1. Step 0.5 is, you can't start to work the steps until you decide to. So that's just this basic commitment to the work of abstinence, sobriety, recovery. There's no manual for it, there's no steps for it, can't tell you how to do it, can't do it for you, you don't have to do it, but if you want to go down the path of recovery, you've got to get real about doing this work. And I mean for real. So that's just say no to drugs. No matter whether you're addicted to drugs, alcohol, eating disorder, or in this way of thinking, you could be addicted to the locus of control shit, because it confers that illusion of power, control, and mastery. Addiction is the opposite of desensitization. There's no such thing as a lemonade addiction. And that's just a fact, that's not lemonade addiction denial. So addiction is the opposite of desensitization. So addictions are transportation vehicles. They kick up a big cloud of dust, they're very exciting, and they take you from here to over there. Here is where you are now, which is bad situation, bad stuff on the inside, bad stuff on the outside. And over there is anywhere except here. Stoned, passed out, distracted. So all addictions are basically avoidance strategies. And what we want to do is understand that and begin the work of desensitization. So desensitization is when you say no to your drug, which is usually drugs. You turn around and on purpose start dealing with what you've been avoiding. And so there's kind of two subdivisions of desensitization: prolonged exposure and systematic desensitization. So if you read APA guidelines on PTSD, they'll say CBT and prolonged exposure. Those are the check, happy face, gold star, approved treatments for PTSD. And then they'll say, well, EMDR kind of has a bit of evidence you're not really there. So this is the internal political warfare between the EMDR mafia and the CBT mafia. And the CBT mafia, who are academic professors of psychiatry mostly, professors of psychology, they're trying to downgrade EMDR, which is actually highly evidence-based with 30-plus randomized controlled trials. But my main point here is they really back prolonged exposure, which means think about it, relive about it, think about it, relive, talk, imagine. And then if you do that, the charge, the hyperarousal energy just sort of tapers down, and then you can just think about it without PTSD. The problem is that the evidence base for prolonged exposure comes almost entirely from academia, so that's a problem. It comes from pretty high functioning outpatients who come in for sessions cooperatively, don't miss sessions. And you can't be like rampantly psychotic. You can't be recovering from your binge last night. So all those people are excluded. So it tends to be relatively well-functioning adults with a single traumatic event in adulthood, like a car wreck, a natural disaster, an assault. Or maybe a limited amount of combat. Kind of any psychotherapy is pretty effective for somebody with a single traumatic event, whether it's this, or this. There's many schools of therapy where you're going to have good outcomes with relatively brief treatments. It's not that difficult. And prolonged exposure is one of those. So it actually, in fact, helps. So it is, in fact, evidence-based because they've done all these studies. So why am I going on about this? If you came as a therapist to work at the trauma program and you said, I'm an evidence-based PTSD therapist and I'm going to do prolonged exposure, you would be causing massive flooding, regression, chaos, symptoms, acting out. So when you do this memory work with chronic severe childhood trauma survivors, it's not only not evidence-based, it's actively toxic and contraindicated. But it gets official billing as the evidence-based treatment for PTSD. That's only true for relatively simple PTSD without too much comorbidity and single event trauma, by and large. So what we want to do is systematic desensitization. Go in, back out. Go in, back out. Little step, which I'll cycle back to and talk about more after I talk about the rectangle. Oh, triangle. So hard to remember. So it's a triangle because it has three corners: the victim, the rescuer, the perpetrator. Should I go over that one more time? Triangle, three corners. Everybody got it? So if it's so easy to remember, how come we keep sliding into the rescuer role without realizing it? Right? So we use this language to track. You could say it's transference, countertransference analysis. We don't want to be in the reenactment. We don't want to be the perpetrators being cruel and mean to the borderlines who deserve it. We don't want to be the pathetic victims who are all burned out because the horrible patients did all these horrible things. We want to be off the triangle, and that's how we can be consultants. If you're just in the triangle, you're just part of the reenactment, you're not part of the solution. So we use this, since it's victim, rescuer, perpetrator, it's automatically a trauma model. It's a systems way of thinking. It's normal English, people can understand it. And we talk about this all the time. And we have handouts about it, and we have trauma education group where we teach it. This is the victim role. What's it doing for you to be in the victim role? Problem's not the problem. What problem are you solving for yourself by being in the victim role? Of course you were, in fact, a victim in childhood. That's not your fault. You couldn't escape it. But what's the victim role doing for you now? Well, that's perpetrator behavior. Okay, now we're calling the police and you're getting arrested for assault. So if it was actually like criminal assault, we would in fact call the police and the person would be taken away. What we do have, though, is a lot of behavioral management strategies to keep things kind of settled down on the unit, because if we were doing all this flooding and memory work, we'd have what I call the borderline Olympics. So 50–60% of people meet criteria for borderline. So they can trigger each other, compete with each other for the worst stories, act out, demand stuff. So we have to be very careful and have good therapy, good expectations, good milieu, and good rules, consequences to keep all that settled down so people can get some work done. And so we don't all get fried out and quit next week. So what's good for the individual, what's good for the milieu, what's good for the staff are all the same thing, a therapeutic milieu. And we track victim, rescuer, perpetrator behavior, talk about it, problem solve about it in groups and in individual therapy all the time. That's all I've got to say about that. One more sip. So somebody comes into the program, could be cutting, could be eating disorder, could be drugs, could be alcohol. So from this perspective, really the treatment for all of these things is the same. So we don't have differentiated treatments for what the diagnosis is or what the behavior is, as much as the DSM makes out. The whole purpose of the DSM is to have these separate categories, as if there's distinct separate treatments for separate categories. This is why if you're treating drug and alcohol people, you can't possibly have a group for people who have been drinking rye whiskey compared to people who've been drinking rum. They have different needs, it's a different addiction. So that's absurd. And everybody can see that's absurd. But we've actually taken subdividing these addictions to an absurd degree everywhere. Of course, people with narcotics problems can relate to each other better, and alcoholics people can relate to each other. But really, when you get down to it, what are the basic core differences between 12 steps for this, this, or this, right? So I'm more interested in the similarities between all the different addictions than the differences. That doesn't mean I'm oblivious to the differences. But by and large, as I said, the problem is not the problem. We're treating the problem in the background. We track, notice, and do some specific stuff about the presenting diagnosis. But that's not really where our focus is. And one reason for that is because we work in an inpatient unit. The average person coming to the program meets structured interview criteria for 12 to 15 different DSM diagnoses. And we have an average length of stay, that's the average, not the record. And the average length of stay is 12 to 14 days. It's capped at 3 weeks. So if somebody's got 6, 7, 8, 10 disorders currently active, we literally could only treat each one for 1 day. So we'd have our treatment plan, we'd have our intake assessment, and we'd be telling managed care, problem number 1, major depressive disorder, here's our treatment plan for Tuesday. Then problem number 2, eating disorder, we'd have our Wednesday. It's just absurd, it doesn't make any sense. It's not gonna work, you can't do it. So we are forced to get to some sort of underlying set of themes, which we do, which is what trauma model therapy is all about. So somebody comes in and their problem is cutting. I'm working with them in cognitive therapy group, which is pretty cognitive, but not like rigid cognitive. In one cognitive therapy group, I might be working with somebody to orient their alter personalities to the fact that they all live in the same body in the current year is 2018, which you will not find in the cognitive therapy literature. But nevertheless, you can say, I'm working on correcting the cognitive error that these are separate people with separate bodies in the current year is 1983. So it's sort of cognitive, but there's a lot of other tools in the toolbox that come in here. And it's not just sort of this intellectualized exercise. There's a lot of affect. That's because I have an arrangement with the Kleenex companies. I get a kickback for every box that comes in. So there's a lot of affect expressed, felt, processed in so-called cognitive therapy. But so I may know the person a little, or I may not know them at all. I may have been filled in briefly or ultra briefly. So I start with, this is a 1-hour group. Where do you live? Who do you live with? Working, not working, studying, employment history, trauma history, parents alive or dead, separated, together, what's your interaction with all of them, how's it going, how are the kids, how's the husband, and why are you here? So I get that story, and then we got like 50 minutes to launch in. What's the main reason you're here? Cutting, okay? So then I want to do a functional analysis, which is, sounds fancy when you say, I'm doing a functional analysis. Actually, it just involves, why do you do that? Literally. This is the functional analysis. Okay, so walk me through the steps. And I don't just go, here's why you do it. I have to ask and draw it out a little bit. But I already know in advance, even though I'm a slow learner, after a few hundred, few thousand sessions, you kind of get the pattern. And it's almost always mood state management. Bad feelings build up, build up, build up, build up, build up. It's intolerable. I try this, I try that. Nothing's working. Cut. And people who chronically self-mutilate, it's really effective. The bad feelings are like gone. Just like shooting heroin. And probably as far as your opioid receptors are concerned, it's indistinguishable from IV heroin because it interacts with exactly the same receptor system. You cut on yourself, pain signals go to your brain, endorphins get released, and oh, bad feelings are gone and I feel okay. So it's probably literally addictive at the same receptor system. So I don't get one of those? So that's why you do it then. And then I want to know a couple things. Either after I ask the next two questions or kind of before, or depending on how that session's going. I'm already thinking, okay, the problem's not the problem. The presenting problem is cutting. And this is the problem that we want to solve. So the person's risk of cutting, self-harm, suicide is low enough that they're now dischargeable to PHP or back to the referring therapist. But in order to solve the presenting problem, we take the approach of the problem's not the problem. Why do you cut? What's the problem in the background? It's a whole bunch of lousy feelings. Why do you choose cutting? Why don't you eat a little bit of Jell-O? Well, because eating a little bit of Jell-O doesn't work. How do you know that cutting works? I've done it so many times. So it's just like somebody with binge eating disorder who also purges. Okay, so you're feeling this, that, or the other. It's time to purge. You focus on eating, eating, eating. The emptiness is filled up. You're distracted from all those feelings. It's all gone away. Life is great. Uh-oh, another 2 seconds go by. Oh my God, I just took on 5,000 calories. Now I've got to purge. Why do you have to purge? Because you took on 5,000 calories and you don't want to gain weight. Nobody would purge if it was scientifically true that purging causes you to gain even more weight. People only do it because it works. Who would have a couple of drinks before a party if it made them more self-conscious and uptight? Right? So all these addictions work short term. Same with cutting. And feelings are gone. So the feedback is, well, so that's smart. You're actually choosing from a repertoire of behaviors something that you know actually works. And if we just looked at it in the short-term window, smart, great. Like, what's the problem? Keep on cutting. The problem is when we step back and look at your whole life overall and what's all the murder, mayhem, chaos, and costs you're paying for your addiction, seems a little out of balance. Seems like the big picture cost is not worth the short-term benefit. But you're not just an idiot. You're somebody who's looking at a range of behavioral options. You're choosing one that works, not one that doesn't work. And what's your basic mission here? You, this horrible addict, this horrible borderline, this genetically defective individual, take away all of those attitudes. You're actually just a smart person who's using a coping strategy that actually works for short-term survival. And what is your mission? Your mission is self-soothing and self-care. You're just trying to get through the day. So we don't need to change the basic nature of your character. We don't need to change the basic mission. We just need to tweak the method a little. So now I've just redefined somebody as not down there in the swamp with the genetically defective mutants who aren't like us normal people, or the borderline or whatever. I said, well, you're just another person who got hit by a drunk driver at a car wreck of a childhood. You're trying to use coping strategies to self-soothe, manage, just like everybody else on the planet. So just pull the person out of the swamp up here. You're like a normal person. Probably needs a little bit of adjustment on some of the coping strategies. So now the project is much more doable. The person's much more hopeful. They're less suicidal. They're less depressed. So in 3 weeks, an average in the program, which is a combination of inpatient and some of the people go to partial for a few weeks, the Beck hopelessness, suicide, and depression scale scores drop by 40 to 50%. Because, for one reason, because this model actually makes sense, it's understandable. You can see that there is real hope. You can see there's a series of steps. You've done several of those steps. You're now here, you were there when you came in. It's not quite so hopeless. And I'm not just this defective person who caused abuse, deserved abuse. It wasn't all my fault. I was just a scared little child. Well, I don't want to feel those feelings. Well, maybe if I feel those feelings and learn to tolerate them, I won't have to do my addictions. So then we cycle back to the conversation. Okay, so I see why you cut then. Same conversation if we substitute eating disorder behavior, gambling, sex addiction, drug alcohol behavior. What would happen if you just didn't do that? That's impossible. Okay, so hypothetically, if you didn't cut on yourself, well then I'd have to get drunk, I'd have to do this, I'd have to do that. What if you didn't act out in any way whatsoever? That's impossible. Okay, so hypothetically, if you didn't act out in any way whatsoever, and the feelings built up, well then I'd have to kill myself. So this is how I learned that cutting is actually not fake, phony, manipulative, borderline suicide gestures. It's actually a suicide prevention strategy. You cut so the bad feelings go away, so you don't have to kill yourself because you're going to make it through another day. That's the majority of chronic self-mutillators. They don't really feel the physical pain because they're very good at dissociating that. A subgroup, though, likes to feel the pain, likes to see the blood, because that distracts them from the emotional pain. And then there's another subgroup where instead of being too hyper-aroused, they're too numbed out, shut down, they're not feeling anything. And seeing the blood and feeling the pain reverses being too numbed out and shut down. But most people, they're too hyper-aroused. So this is the window of tolerance that Dan Siegel invented. When you're above your window, you're too hyper-aroused. When you're below it, you're too hypo-aroused. And the idea is to be in that window, make the window bigger, and learn how to modulate yourself inside the window. So now I've coined another term, which is the window of intolerance, which I explain to people. I may explain the window of tolerance, and then I'll explain, here's this other idea I've made up called the window of intolerance. And that is, your feelings are up here because of all this stuff you went through. Most people don't have feelings, they're ramped up there. And your coping skills are way down here, because in your family, nobody had healthy coping, nobody taught it, you didn't get to practice it. So the gap between your level of arousal and your coping strategies is this big. This is your window of intolerance. The average person, their feelings are here and their coping skills are here, it's a piece of cake. So the reason that you have to resort to all these maladaptive behaviors is perfectly understandable. You were gifted in your childhood a very big window of intolerance. So you're not abnormal to the core. It's understandable, it can be worked on. Let's get to work on it. So then, now people are getting really desperate because how are they going to continue to rationalize and justify their addiction now? Okay, well that's easy for you to say, Dr. Ross. Yeah, so this is why it's a lot better to be the doctor than the patient. I get to say it, you have to actually do it. Easy for me to say, not so easy for you to do. But, nevertheless, we're back at just say no to drugs. When are you going to make this really serious commitment to not cutting anymore? I don't know how. So, rationalization number one, I don't know how. There is no how. That's just an untruth you're telling yourself to justify not starting the process of recovery because you don't know how. We're not talking about the implementation phase. We're talking about the commitment phase, step 0.5. There's no point in talking about how to do it if you're not committed to trying. Oh, well, I'm not strong enough. So then they'll go to I'm not strong enough, which I already know for an absolute scientific fact is not true. How do I know that? Okay, so let me ask you a question. When you were 7, how old were you? So, I'm an expert on asking weird questions. What do you mean? Oh, so when you were 7, you were just 7 years old. And you survived what kind of a childhood? When you were just a little kid, you were strong enough to survive all of that? And now you're telling me you're not strong enough to stop drinking, stop cutting, stop binging? This is a negative myth you're telling yourself about yourself that you've disproven by surviving your own childhood. Oh. And so sometimes I also say, this is called cognitive therapy, but actually it's painting them into a corner therapy. And the person who's working with you is like, oh, and everybody else in the group is like, oh. So you're kind of running out of rationalizations and justifications now. So then we're gonna get to locus control shift. It doesn't have to be in this exact sequence. Well, it doesn't matter if I'm cut on myself. Oh, okay. Self-blame, self-hatred, I'm not a member of the human race. I deserved it back then, it's okay to cut on me now. So then I wanna have the person look at themselves through somebody else's eyes. So it's kind of like a Gestalt chair thing. And so they can be in the other person can be in them, they can be in this chair, they can be talking back to themselves. There's all these combinations. So you have a 12-year-old daughter, right? Right. If not, hypothetical daughter. She comes home from school, worst day ever, and she says, Mom, would you teach me how to cut on myself? I know it works for you. What would you do? I've yet to have somebody say, oh yeah, I teach her how to cut. It's always, I get her therapy, I do whatever it takes. Well, why? What do you mean? She's my daughter. So? Well, I love her. Oh, I see. You love her. What did she have to do to earn that love? Nothing. Oh, so it's unconditional love. Uh-huh. And then sometimes the person goes, oh, I see where you're leading. And the rest of the group's going, there's clearly a double standard here. Why is it okay for you to cut on you and not okay for your daughter to cut on herself? Are you telling me that if I love myself the way I love my daughter, I wouldn't cut on myself? Exactly what I'm telling you. Remember we went over locus control shift? You're not actually addicted to cutting, you're actually addicted to the locus control shift. Because you have to hate yourself, say it's okay, I'm just a this, that, and the other, it doesn't matter if I cut on myself, in order to rationalize and justify the behavior. Oh, now she's really painted in the corner. And so if we're in a group that ends at 1, so no hurry, we've got 9 minutes. When is it you're thinking that you might make this commitment to recovery? When I get stronger? Don't know how? It doesn't matter. Okay, we've canceled all those rationalizations. Are you thinking, when it was in the late 90s, I used to be able to go, what millennium are you thinking? Now I just have to go, what decade? So you think like this decade or next decade? Nobody goes, well, I'm going to keep my addiction going for another 10 years. And you can't sell that in an AA meeting. So soon. What do you mean by soon? Well, maybe in like 3 months or 6 months. Oh, I see. So you're giving yourself permission to continue to cut for at least the next 6 months. That doesn't sound so good. No. So I'm not saying that the whole rest of your life is going to go fine, that you're not going to have any crises. Actually, what I'm talking about is a policy decision. Right now in the present, you're not overwhelmed, you're not flooded, your cortex is not shut off because your limbic system is ramped way up. We're just having a conversation. I'm asking about your policy right now concerning cutting, drinking, binging, sex addiction in the future. Is your policy that you're going to keep it in your back pocket as an option in case you need it, or not? So I'm talking to a self-mutilator. So if I'm talking to somebody who cuts, I can make the point by talking about those crazy alcoholics and all those crazy thoughts they have. If I'm working with somebody who has a drinking problem, I could go, oh, these people who cut on themselves, they say the following and believe the following. Because it's so easy to see what's wrong with those people, not so easy to see what's wrong with you. So I'm talking to the cutter. So somebody's at an AA meeting, and they stand up and they go, well, okay, it's good for you guys, but my job is so high pressure and I have so much responsibility that I just have to drink. Does everybody go, you're an exception? Yeah. Like, it doesn't sell. Nobody buys it. We've heard that story before. When are you going to get serious about recovery? So that's the cool thing about the 12 steps is, like, there's no out. There's no wiggle room. And if the person doesn't make the commitment to recovery, you don't go, this 12 steps model sucks, there's something wrong with it. You just go, they're not working their steps. So it's never the fault of the therapist, it's never the fault of the model, which I think is cool. But it's actually true. So we're just back to, when do you think you might make this decision? But don't worry, we've got 6 minutes now. And so in the course of this process, I I do get kickbacks from the Kleenex companies because people start crying. It's very heartfelt, and they make what seems to be a for real, serious commitment. Then I want to check on it. Okay, back to the AA meeting. One guy stands up and says, "Hi, I'm Joe, I'm an alcoholic, and I'm committed to working my recovery one day at a time." That person means I'm totally committed, I can't slack off for one day, I'm on it tomorrow, the day after, the day after, the day after. Next person says, "Hi, I'm Bill, an alcoholic." And probably shouldn't use the name Bill, because I'm an AA name. "And I'm committed to working my recovery one day at a time." Exactly the same statement, but what did Bill mean? He meant, I never said I wouldn't drink next week. So he's got this little out clause for himself. But he's talking the talk, he's just not walking the walk. So, when you say you're not gonna cut, and that's it, and you're serious, do you believe yourself? Well, not really. Oh, okay. Or, kind of, or I'm not sure, or definitely yes. Okay, so if you're not really there yet, what's the good of a fake commitment to recovery? You could fake me out, but what good is that going to do you? So if you're actually not there, well, that's good. You're being honest with yourself. You're being honest with me. It's not a crime. Hopefully you can get there before discharge. So that's how that talk goes. Oh, now we have 5 minutes. A question or a thought or a comment about that? Maybe I'll talk a little bit about the disease of alcoholism. So I've just kind of given an ultra quick feel for how this model operates. We certainly have people come in and say, alcohol runs in my families. If you look, I always forget the number. It's an amazing number of times. It's like 34 times in the DSM. I actually counted them up and wrote a paper about it. So if you go through the different sections of the manual, it's got the diagnosis, it's got the category, like mood disorders, anxiety disorders. Then it's got the individual diagnosis, it's got the criteria, then it's got the text, and there's subheadings. And one is sort of causal factors. I forget the exact wording, but it's basically causal factors. And then that's subdivided into environmental and genetic physiological factors. And there's like 27 or 34 times throughout the DSM. Under the heading of genetic and physiological factors, it says that the disorder runs in families. Never once in environmental factors does it say the disorder runs in families. And this cognitive error I always taught when I was going through my residency back in the 80s. Runs in families is evidence of genetic causation. Which is certainly true because we know that there's a gene for speaking Chinese. And the reason we speak English is because we have the gene for speaking English, right? Because it runs in families. Everybody in our family speaks English. It's so transparently obvious that that's not true. That something can run in families at a very high rate and be totally environmental. Also, something can run in families and be totally genetic, or some half and half combination. The simple fact that something runs in families does not tell you at all. It could be, but it doesn't tell you at all that it is genetic, biological, medical, or disease. It could equally as well be totally caused by the environment, be learned behavior. So this is like the American Psychiatric Association has officially endorsed dozens of times in DSM-5 that something running in families is evidence of genetic causation. It just is absolutely not scientifically true. It's a cognitive error. I say that when I'm in a polite frame of mind. When I'm in a less polite frame of mind, I say it's a delusion. I mean, it's actually technically delusional thinking. It's a shared false belief. It's not consistent with basic logic. Okay, so alcoholism is a disease because it runs in families. Reject. There's no debate whatsoever. So in medical school, I dealt with people who died within a couple of days from complications of alcoholism, a couple of days of admission. So they had a disease. People vomiting blood, people in coma, and we give them some med and wake them up temporarily. obvious mass of people who, like, when they stand like this, and you ask them to close their eyes and you give them a push, like they almost fall over. Massively disturbed gaits, cognitive impairment. So it's clear that drugs can cause a disease state. There's just no debate about that. The question is, does a disease state cause you to start using drugs and alcohol? Actually, in fact, there's no scientific evidence that that's the case. What does it say in DSM-5? What does the NIMH say about this? In the DSM-5, it says there are and this includes in the substance abuse section, there are hundreds of risk genes for this disorder, in this case substance abuse, but it's the same set of several hundred risk genes for substance abuse, depression, bipolar, schizophrenia, autism. There are not separate genes for separate disorders. This is the official position of the APA and in the NIMH. So there aren't specific genetic causes for substance abuse. And each one of these individual genes by itself confers a maximum of 1 to 2% of the risk for the disorder. So this is not some like fringe, conspiracy theory idea. This is the mainstream hardcore of the APA and the NIMH saying that there is no biological test for any mental disorder that's at all specific or useful clinically, meaning there's no medical evidence that these are actually diseases before the substance abuse starts. There's no evidence whatsoever of any specific genetic causation, and the fact that it runs in families proves nothing. It could be entirely learned. So I think we're erring by overemphasizing the disease model. And one problem with the disease model is, oh, sorry, I forgot to tell you, I have cancer of the pancreas and I have to go because we've got Cancer of the Pancreas Anonymous meeting at 2. Because we're treating cancer of the pancreas with the 12 steps. That makes sense to anybody? No, if I had an actual disease of cancer of the pancreas, nobody would try and treat it with the 12 steps. Because it's actually a disease. 12 steps didn't work for diseases. So if alcoholism actually is a disease, why are we using 12 steps when it doesn't work for diseases? It's a metaphor. What's the purpose of the metaphor? Well, that means doctors are in charge and psychiatrists are smart and we can get more funding and it's not your fault. But if it's not your fault and it's a disease, then what are you going to do psychologically to get into recovery? I really don't like this arthritis of the hip. I'm going to work on my psychology so I don't have it anymore. It's not going to work. 12 steps or any recovery model can only work if it's not actually literally a disease. That's all I have to say. Thanks for listening.